So we do have the QHSC training, treatment and management of intubated patients. As I said, we have a lot of panelists here, and then there will be we have our presenters today, Zachariah, Alisa, Dr. Gwen, Dr. Helen, and Miss Kathy. And I'm gonna let them introduce themselves, and then so you'll be able to see them. Okay. Starting with Mr. Lisa.
Good morning, everyone. My name is Alyssa Karavitis. I am an ICU nurse. I live in West Palm Beach, Florida, and I've been an ICU nurse for about a year now. So, of course, I'm BLS and ACLS certified, and I've also been a member of QHSC since 2023, and I came to Tanzania with everybody in, again, 2023. So very happy to be here, and if you have any questions, please feel free to ask during the presentation.
Ms. Kathy.
Good morning, all. Thank you for having me. My name is Kathy Dolgus. I'm also an RN, and I'm a paramedic as well. I started out on a ground ambulance unit, ended up on a helicopter somehow, well, ER and then helicopter. And probably my best ICU experience was on the helicopter, believe it or not. And I have otherwise working in the ER and PACU and ambulatory surgery. And I am certified in most of the AHA, well, all of the AHA education, the ACLS, PALS, and BLS. And I love training. One of my big favorites would be a trauma class that I am faculty for, which is ITLS, which is an international trauma life support. So who knows down the line if we want to do something with that, I'd love to do that. I'm also a mom of 2 married girls that are wonderful, love them, and I have 5 grandkids, and it's so much fun. And my husband's David, who is a huge support of me going into this venture. Thanks for having me.
Thank you, Ms. Kathy.
Thank you.
And then we have our panelist, Dr. Helen. Do you want to say a quick hi?
Hi, thank you for having me. I am Helen Walter, a Tanzanian, a medical doctor working in ICU, currently at Mwananyamala Regional Referral Hospital. I've been working in ICU for 2 years now. Yeah.
Thank you very much, Dr. Helen, for joining us. Dr. Gwen, our very own.
Yeah, good morning.
Good morning.
Dr. Gwen Randall. 30 years practicing as a nurse anesthetist, and I've been around the block a few times. I've been to Africa numerous times, and I was in Tanzania in 2023, I believe. And I really enjoy teaching, and I've maintained my relationship and association with the ICU team since leaving. And so I'm really glad that everyone is participating. And we look forward to your questions.
Thank you, Dr. Gwen. Mr. Zachariah.
Thank you. Hi to everyone. My name is Zakaria Kapuru Venus. I'm from Tanzania. Currently, I'm working in ICU at Mwananyamala Regional Referral Hospital. So I'm a registered nurse holding a Bachelor of Science in Nursing as a nursing officer. So thank you and welcome to Tanzania.
Thank you very much. Okay, so let's dive in. Mr. Lisa, go for it.
All right, today our objectives are that we're going to be identifying signs and symptoms of a patient in respiratory distress, which I'm sure you've seen numerous times. We're going to talk about indications for mechanical ventilation, identify management of care while a patient is on the ventilator. We'll articulate our nursing interventions for caring for an intubated patient, and also recognize some criteria for extubation. Okay.
So, hi to everybody. Welcome in our discussion. I will take you through the scenario. So, I can start?
Yes.
I can start?
Yes, you can.
Okay. 67 years old female with chronic condition, hypertensive and diabetic mellitus type 2, presented to the ICU with complaint of coughing and increasing shortness of breathing for 2 days. Patient reports taking medication. Patient reports taking home medications for hypertension and diabetic regularly. The patient is replaced on a non-rebreathe face mask prior to arrival in ICU. Next slide. So the vital signs taken, the blood pressure was 140/90 millimeter of mercury, heart rate were 122 beat per minute, respiratory rates were 35 breaths per minute, oxygen saturation were 89% on non-rebreathe face mask. Body temperature were 37.2 Celsius. For those who use Fahrenheit, it was 99.0 Fahrenheit. The random blood sugar were 10 millimole per liter or 180 milligram per deciliter. Ketones were negative. Next slide, please. Also, the physical assessments were done. Uses of accessory muscles during inspiration were inspected. Clacos sound bilaterally were auscultated. Bilateral edema or lower leg swelling were also examined. But patient, she was alert, but unable to speak in full sentences. So lab and radiological tests were performed, full body profile, the chest X-ray, and the EKG. ABG demonstrated pH were 6.98, partial pressure of carbon dioxide were 58 millimeters of mercury, partial pressure of oxygen were 7 millimeters of mercury, and the bicarb were 28 millimoles per liter. Next slide. Next, please. So welcome to our discussion. And the next presenter, Michaela.
Well, I think at this point, what we would like is, based on the information that we've given you in the scenario, we'd like to have some input in terms of what you think is actually going on with this patient, based on the data that you've been given. What are your thoughts at this time? The last slide. Go back to the last slide.
Response. Yeah, the last slide.
The lab results.
Let's see if you can show the vitals. Yeah.
Okay, if you have any comment, guys, put it in the chat, then I'll be reading them.
So the differential diagnosis that we're looking at is congestive heart failure. And, why did that happen? Possibly her blood pressure out of control. Could also be congestive heart failure relating to prior MIs, or somehow her heart is a little tired. She has bilateral pleural effusions. She's developing ARDS, if you remember seeing the chest X-ray. And if you remember looking at the blood gases, it's showing an acidosis and a little bit compensated, not a lot. She's probably on the headed towards the decompensated side. And then developing pulmonary edema, which is related directly to the congestive heart failure, usually. Diabetics can tend to be prone to this whole situation, and it's also obviously a risk factor, comorbid factor. Okay, I'd say next.
Okay.
So, considering this patient is now in CHF, congestive heart failure, the heart is not pumping effectively, like Kathy was mentioning. This could be because of ischemia, previous MI, the hypertension, any type of valvular disease, if they have a history of murmur, a history of valvular regurgitation, myocarditis, and we'll look to diagnose typically a CHF by looking at the left ventricular ejection fraction. So via ultrasound, they'll go and check the ejection fraction. Normally, we're looking at 50 to 70%. Many times, if you're starting to get symptomatic CHF, certainly less than 50%. Sometimes it's as bad as 20%, 15%, depending on how long this has been ongoing and untreated. So symptoms, as we've seen in this patient, there's edema, both pulmonary and bilateral lower leg extremity edema, the shortness of breath, fatigue. Sometimes they'll have the jugular vein distension, and sometimes when they'll cough, they might have a productive cough with frothy sputum.
And another thing about the JVD, just a reminder that that's something that is best assessed, not with a patient supine, need to be up like 20 to 30 degrees to assess that. And then just another idea on the symptoms that oftentimes, and not always, because you don't know when you see the patient, are you seeing them early in CHF, in the middle of it, or post? And where they're starting to decompensate, but very often their blood pressure is very high and you usually have a lot of blood pressure to work with as far as treating the patient. But sometimes they are starting to decompensate and their blood pressure is not quite that high.
Thank you, Kathy.
Mm-hmm.
Dr. Helen?
On the initial management, carrying on from where Zakaria ended, we kept the patient on the CPAP, the non-invasive positive pressure ventilation, for 2 hours. Well, also we did the control ABG as well. Since the patient had, on the cardiac monitor, the patient had BP of 130 over 89 millimeter mercury and heart rate of 130, respiratory rate 36 breaths per minute, and temperature was 36.6. The ABG's results done after the 2 hours on CPAP, pH was 7.02, partial pressure of carbon dioxide was 60, and partial pressure of oxygen was 90. The bicarbs were 30 millimoles per liter.
So despite putting the patient on our CPAP, she's still in respiratory distress. So signs of respiratory distress, tachypnic, so her respiratory rate greater than 30, labored breathing, short of breath, dyspneic. The retractions, so you'll see around the sternum, around the rib cage. Sometimes they'll have abdominal breathing or mouth breathing. A lot of times, because they feel like they're not able to breathe, they become anxious, they have high anxiety, they become confused due to hypoxia or hypercapnia or a combination of both. You might notice peripherally, and this would be a later stage, that they become cyanotic, dusky in color, or even blue in color. But that should be a little bit later on if they have not been closely monitored or if they're coming in late respiratory distress.
So indication for intubation during surgery or general anesthesia. We can intubate the patient to protect airway. Maybe has a lot of circulation, mucus. So we intubate it to protect the airway. Also, for those patients with respiratory distress, as we have seen above the slides there. Also, another indication for intubation, it might be arrested the patient, cardiac arrest. So you have to intubate and continue with the post-cardiac arrest management. Also, for those patients with ineffective gaseous exchange. So you intubate the patient so as to correct the gaseous exchange or to make it effective. So those can be few indications for intubation.
I'll just
So to
add,
our patient,
sorry to interrupt. I just want to add also for airway protection, if patient has been in an accident or if they have some sort of facial trauma, that would also
trauma, yeah,
be
of
a
course.
reason to protect the airway if you're expecting lots of swelling because of trauma or even a burn. So that would also be a reason to intubate. Again, under airway protection, if you have a patient who is overdose on medication, they
Exactly.
can't initiate their own breathing despite, giving any Narcan or reversal agent as well.
Yeah.
Just saw comments as low Glasgow Coma Scale. That would also be indication, yes.
And just a reminder that even though you have the indications for intubation, that you still need to ventilate first. So you may be going from CPAP to initiating sequence intubation, but first you need to get an airway in and you need to ventilate the patient to you and make sure you also resuscitate the patient before you give the drugs, getting ready for the intubation.
Okay, next slide. So with anything, there are risks and benefits. When you intubate, there's always risk for a pneumothorax, either initially when you're inserting because you want to stop at the carina or just above the carina. Occasionally, it can start to enter a right lung, causing pneumothorax, or because of the ventilator settings, you can later develop a tension pneumothorax. So it's important that we are auscultating for bilateral air sounds as well as monitoring trachea for shift. So again, when the patient is on the ventilator, they can become at risk for ventilator-associated pneumonia when the moisture builds up in the system, can lead to growth of bacteria. Patients become delirious because you are sedating them. They become confused. They are at risk for aspiration, especially if they are receiving tube feeds as well. Pressure injuries, because again, they're sedated, they're not moving, they're unable to turn themselves, as well as pressure injuries within the mouth because of the tubes constantly pressing against lips, teeth, tongue. And of course, if the patient already has dentures or any issues with their teeth as you insert the tube, could also lose teeth. And sometimes patients bite on the tubes during treatment. Benefits. So if they need to have a surgery, you're able to sedate them safely and put them under general anesthesia while protecting their airway. It decreases the heart and lungs workload. So if they are already in respiratory distress or if they've had a cardiac arrest, at that point, we're able to protect their airway and ventilate them and decrease that workload. We're correcting respiratory acidosis or alkalosis. So in this case, with the patient is in respiratory acidosis, again, we're securing the airway and we are preventing death in cases of complete respiratory failure.
I think this is me. So we're progressing on where I said we have decided to intubate. So we are resuscitating and we are ventilating and making sure we get some vital signs that are reasonable to be able to take over this patient's airway by using some sort of an anesthetic and a neuromuscular blocking agent. And those choices, especially for this patient, the ketamine is an excellent choice. Because it not only does it do a good job with as far as an anesthetic, it also works on the bronchioles and helps open things up a little bit, which will also help with the oxygenation. So good choice with this one. And the other thing is we're going to be giving medications that are going to probably lower the blood pressure, and this will kind of keep it at a fine, happy medium. Looking at ventilator settings, and this will be case by case, and it might change even, after their initial settings. But looking at a volume assisted control, and then you're looking at tidal volumes, and the choice on this one was 400 with a utilization of 60 kilograms. And we'll talk in just a little bit about tidal volume, if you don't mind. And then also the respiratory rate at 25 breaths per minute, with the idea being you want to try to come close to matching what their previous respiratory rate was, because you're not going to try to change somebody from acidotic to normal like immediately. That's a hard thing to do. And looking at 100% oxygen right now, that's something that can be toned down and weaned down later, but for resuscitation it's 100%. PEEP starting out at 7, oftentimes it is much higher than 7, depending on how they respond to this. And know that, a normal PEEP is somewhere between 3 and 5, and that's without any sort of adjunct on us. That's us on a daily basis. So 7 is not that much, especially for a CHF patient. Okay, next.
Back to Dr. Helen.
Okay, so carrying on from the initial management, plan of care and interventions done in ICU. We gave furosemide 80 milligram IV BD. Ceftriaxone, we kept the patient on antibiotics, covering with ceftriaxone sulbactam 1.5 gram IV BD, metronidazole 500 milligram IV TDS, pantoprazole 40 milligram IV OD, paracetamol since patient had episodes of fever. So we covered with paracetamol, 1 gram IV TDS, enoxaparin, 40 milligram subcutaneous OD. And since she's a known diabetic patient, so insulin BD dose. Also, we continued with ketamine infusion. Covered the patient with losartan, 50 milligram OD per oral. Also, junior aspirin, 75 milligram per oral OD. Yeah. I wish someone else to tell us more about nitroglycerin drip for CHF with pulmonary edema, since we never covered this.
Okay,
this medication.
I can do that. You want me to do that, Alyssa, right?
Well, I just
Yes,
I
you can
just
cover
have
it.
a question.
So I understand that I had brought up the nitroglycerin idea because that's something we use very commonly, especially with the pulmonary edema, not just congestive heart failure, but symptomatic pulmonary edema. And it's an aggressive type treatment, and actually one of the first line medications that we give, besides obviously the best drug we have, which is oxygen. And remembering that, the whole idea is to take the workload off of the heart. And it obviously is also going to lower the blood pressure, and you got to watch the blood pressure really close and treat hypotension that is cardiac related. Also, there's going to be some contraindications to giving nitroglycerin to any patient. Obviously, with any sort of ED medication in the past 72 hours or 24 hours, depending on which medication it is. But then the other thing is that you have to think about if they've started out really hypotensive, being aggressive with nitroglycerin is very risky. But usually they're starting out fairly hypertensive or at least normotensive. And what we usually do is, so that's what we use as our first line vasopressor. And dobutamine after that is actually what we use as far as to help with the heart contraction and that. But as far as the nitroglycerin goes, you can start out with sublingual nitroglycerin just like anybody would take at home. However, if they are in like a flash pulmonary edema, or they're not getting any better, we actually do very aggressively with a nitro infusion. And it's actually a little safer to go the infusion route, because once you do a sublingual nitro, you can't take it away. And you've given a fair amount of nitroglycerin going sublingually. And usually they start out at, like, each spray is like a 400 dosage. So the thing is, we usually end up with like 3 sprays or something like that, or sublingual tablets, whatever you have. So as far as a drip goes, we usually start pretty high, and it sounds crazy high, and it's like in the range of like 40 mics a minute, which sounds crazy, but knowing that you can turn that off right away if you have any issues with it. But the goal is to be aggressive early on with nitroglycerin to get its reaction, to try to return some normalcy to the lungs and the pulmonary edema, so that they can start to get oxygenated. So the biggest goal of this is to take the workload off the heart, especially the left ventricle, and then to oxygenate, get it so the patient can be oxygenated well. Does that help? There's a lot more to it, but does that help a little bit? Anyone?
Thank you, Kathy. I know Dr. Gwen, you wanted to say something before.
Oh, I wanted to find out why they maintained the patient on ketamine, and was propofol ever a consideration?
Dr. Ellen, no, Zachariah.
So I had also posed this question when I first received the scenario, and I was told by one of the pharmacists that in some cases they prefer ketamine because they worry about hypotension. With this patient having hypertension previously, it's likely possible you can maintain them on propofol.
Honestly, it would be nice to do both, like a low dose propofol with a low dose sedative along with it. But I agree, the propofols are very nice. I love ketamine, so I use ketamine a lot, and I feel comfortable with it, especially with its other effects, the bronchodilating effect especially. But the mix of the two, or any other sedative, I like.
Yeah, we also tried ketamine over propofol, since ketamine, due to the effects of bronchodilation, yeah, in this case.
Okay, thank you guys. Benedetta Everest asked why metronidazole?
So
This patient got metronidazole.
because we are going to try to treat on all fronts, there's also a possibility that the patient will develop pneumonia from all this pulmonary edema. So we're also going to be giving broad spectrum antibiotics with the ceftriaxone and the metronidazole, just to avoid the growth of any, bacteria, yeast infection, try to prevent or treat any early infection.
Okay. Dr. Hen, did you want to say something? Or maybe I hear back and forth. Did you want to add anything or no?
No.
Okay. Okay, that's fine. Thank you, guys. Okay, so let's go to the next slide. Go ahead.
Who is that? Is that supposed to be me?
I think it was Zachariah.
Oh, okay. So the nursing care plan, or the nursing diagnosis that diagnosed this patient, it was impaired gaseous exchange related to pulmonary edema or congested heart failure, as evidenced by low SpO2 oxygen saturation. So another nursing diagnosis were excessive fluid volume related to congested heart failure, as evidenced by lower limb edema. Another nursing diagnosis were activity intolerance related to sedation. Sedation effect as evidenced by unconsciousness because the patient was sedated with ketamine. Also, the potential nursing diagnosis were risky for VAP, ventilator-associated pneumonia related to endotracheal tube, ETT in situ. So those were nursing diagnosis that we diagnosed this patient based on the case above.
Okay, thank you.
Thank you.
Okay, so to start off, they arrive in the ICU. They should be placed on continuous cardiac monitoring with hourly vital signs. They're going to be monitoring input and output hourly. The Q2 blood glucose, and I'll mention this later, because you're giving, I believe you said like 3 times a day insulin, and then at night, you probably don't need every 2 hours blood glucose monitor. It might just be like to follow the sliding scale. If they start to, not respond to the insulin, then or that you suspect DKA, then maybe you could go to every 2 hours or every 1 hour glucose check. But for a patient who is well controlled with an insulin dose, you likely don't need as frequently. The 2 hours, maybe you could go every 4 or 6 hours with glucose check. Term patient every 2 hours. Oral hygiene and body hygiene daily. Again, we'll talk a little bit about frequency, about what we do as practicing in the US later on, and then feedings as ordered by physician. So in the US, I don't know if titrations, if that's how orders are written in Tanzania, but for working in the US, like if you have a sedating medication, for example, propofol, a lot of times that you're able to titrate that medication to have a good dose instead of like one dose for everybody. So it will say, you can start at however many milligrams per kilogram per hour. And then depending on how the patient is responding, and we use the RASS scale, and how sedated that patient is, you can either go up or down. So you might start at 10 milligrams per kilogram, and then you can go up by 5 or down by 5, depending on if the patient is moving, competitive, attempting to pull, or if they are, a -2 is usually what we look for, -2 to -3, where they're resting, their eyes are closed. But if you go and you verbally try to wake them, they respond to their name, they open their eyes, they can follow some commands. That's kind of what we look for. But as soon as you stop, kind of walk away, then they go back to an unconscious state. So that RAS of -2 is usually what we titrate to. And then this also, you would also try to do a daily sedation vacation where you pause all of your sedating medications to try to wake the patient, see where they are at neuro-wise, do a neuro assessment, and hopefully minimize delirium by not over sedating your patient, and also by giving them a break of sedation and being able to see neurologically if they're being affected by your sedation, negatively, I should say. So any comments on this? Do you guys do titration-based orders, or is it usually whatever is prescribed?
And that's the question to Dr. Helen. Yeah. Mm-hmm.
I think this is a good input. We don't normally follow the RASS score, but I think we should start this. Yeah.
That's good. I think it's something that we can share afterward, and then share more information. I'm sure Alisa has a lot of information to share, or even Kathy and Dr. Gwen, to share about this score, and then to make sure if it's something that is practical and possible to be done in Tanzania, that would be great. So we can learn a little bit the background of it and how to put that together, reflecting what you guys have currently in Tanzania. So that's a good thing. Thank you.
Thank you.
The next one, Alisa.
Going along with this, the same can be done for any pain medications. Where I work, it's very common that we have a patient who's intubated on propofol and fentanyl. So if I was giving fentanyl, the way I would titrate, the medication to suit that patient's pain level, because they're not able to respond or tell me what their pain level is, we would use a tool called CPOT, which is the Critical Care Pain Observation Tool. So does this patient have a tense face? Are they grimacing? Do they try to protect themselves when you move? Does their body tense up? Do they kind of try to push your hands away? Again, that would be an indication that they're in pain. Or are they restless? Do you see them kind of like moving their legs, moving their arms all the time? That is also one of the indications of pain using the scale. Again, muscle tenseness. Are they like stiff like a board without any other history of like contractions or any other explanation for the tenseness? Ventilator compliance. Are they trying to breathe over the vent more than expected? Are they coughing a lot on the ventilator? Are they completely asynchronous with the ventilator? So those are also things that we would look at as signs of pain. So kind of the CPOT and the RAS are used in conjunction to determine if the patient is adequately sedated and if pain is managed correctly.
If I can also suggest, there's another scoring. It's called the POS score, POSS, and they all have their different purposes. And the purpose for the POS score, the O of the POS score is opioid. So the idea of is a post-opioid type of sedation type scoring. So the goal of it is to make sure you don't overdose the patient and you start to realize what's going on fairly early. So it's not always necessarily one or the other. It might be in conjunction too, as well as the CPOT. And whereas the RAS score is where, as Alyssa was saying, you're looking for movement and response. The POS score is something you're looking for to make sure you don't oversedate. So that's another nice tool.
Yeah.
Dr. Helen, what are you guys using in Tanzania in terms of management? When the patient's on the vent, what parameters are you using?
Yeah, we are familiar with the CPOT. Yeah. Mm-hmm.
Okay. And then, of course, if like you're always zero, you can try to titrate back and do a lower dose of your pain medication. And unless you have, typically we try to be less than 2 for the CPOT score. So then if after you turn down, if they stay at 1 or 0, then you probably didn't need that higher dose of the medication. If they go up to 3 or 4, then you probably should go back to the original dose that you had. So it's, you're not just titrating up, you're also titrating down based on need.
Dr. Helen, are you guys also using any kind of opiate? What do you use for the opiate?
The sedation score.
Oh, we normally use ketamine because it acts as both analgesic and as an opioid. We have no morphine at our setting, so
Exactly.
yeah.
You have fentanyl or no?
No,
No. Okay.
no,
No, we don't have.
we don't have.
Okay, so that's something that we can still try to identify the available drugs, what we use here in US, and then available drugs in formula in Tanzania. And then we do have pharmacists who from Tanzania who works with us, so we can collaborate with that within also including Zachariah and Dr. Helen to be able to figure out what are the available drugs, possible drugs that can be included in this tool, and then see if it works with what they currently do. So that's great learning opportunity there.
Yeah, sure.
Okay.
Yeah. And then before I forget, people who sign in, please put your name and the hospital where we come, because we always like to know which hospital you're coming from. So then if we have anything specific, like right now, we can say, okay, this hospital can go and communicate with any finding that you might be helpful. Just put your name and the hospital on the chat. So that will be great. Okay, let's keep going. Nursing interventions.
Okay, so in my practice, what we'll do for infection prevention, mouth care, we try to do at least every 2 hours, either at least once with chlorhexidine mouthwash, and then following that, it can be, you know, a different type, like a peroxide or a non-alcohol based mouthwash. Body hygiene, again with the chlorhexidine, is every 12 hours or once a shift for us, as we have 12-hour shifts. The Foley care should also be done every 12 hours. And then we try to utilize an ET tube and a system that has inline suctioning to avoid exposure to additional bacteria from while suctioning. Again, to prevent pressure injuries, we're turning every 2 hours. We have to be careful of our medical devices. So the ET tube, the holder, the placement, because that can also cause pressure injuries around the mouth or on the lips. And we have a holder, and I don't know if you use primarily tape, or if you have what type of ET tube holders you have. But if they have a clip where you can easily reposition the tube within the mouth during mouth care, you know, you just move it side to side a little bit just to avoid consistently having it always on the same side. And then we're looking for moisture related skin breakdown. So, you know, if you're a patient, even if you just wash them, you turn around, you come back, they're diaphoretic, they're incontinent, you know, you have to kind of keep managing that because moisture related skin breakdown is an issue. We are going to be monitoring our intake and output. So if you have a Foley, you're calculating your drips. So you want to keep, you know, track of how much is going in, how much is coming out. We're oscillating our lubs for improving the crackles. We're going to be rechecking our ABGs at least once daily, or if ventilator settings are changed, then they will also do a repeat ABG after a ventilator setting change to see if the patient is responding well to that new setting or not. We have portable chest x-ray, which I don't believe the hospitals in Tanzania have available, but we'll try to do like a daily chest x-ray to compare to previous chest x-rays to see if the pulmonary edema is improving, or if like the patient is in ARDS, to see if, again, if the x-ray is better or not. For tube feedings, we're going to be checking residuals. So usually about every 4 hours, if it's a continuous feeding, or if you give a bolus feed, probably like an hour or two after a bolus feed, you want to check. Because again, if the patient is not digesting the feeds and you continue to give the feeds, there's a risk for aspiration if the patient is not able to digest, and you don't want to have aspiration of your stomach contents into, of course. Lab work will usually do at least CBC and a CMP if you suspect infection, or if they had a previous lactic acid elevation, you'll do trending lactic acids. And then in this case, with the patient being in CHF, you could also do a pro-BNP to see, or if you suspect any kind of ischemia, myocardial infarction, you could do a troponin. Blood sugar, I touched on this earlier. if you have a sliding scale, oftentimes we'll just do, for the sliding scale, or every 4 hours. Or if there's no history of diabetes, you could do like every 6 hours, because you just want to make sure that like they're not becoming hypoglycemic because of the frequency of tube feeds, or that they're not becoming hyperglycemic due to, again, either the tube feeds or some of the medications that might raise blood sugar. Okay. Any questions about this one?
Thank you, Lisa. And Kathy, yes. You're
Okay,
next.
this is ventilator training and ventilator information could be a whole couple hours long, a couple days long training. So I tried to at least hit some higher points on the next couple slides with some suggestions. If you have any questions or anything like that, let me know. I know there's someone on here with anesthesia experience. I'm sure they can help with this as well, or any of us, I guess, any of the doctors in that. So the idea is usually what you want to do is come up with what you want their tidal volume to be and when you're coming up with ventilator settings. And usually when you have somebody that is in CHF pulmonary edema, especially if they are developing ARDS, which is acute respiratory distress syndrome, you usually want to do a little bit less tidal volume. However, in order to keep a tidal volume normal, if you go down on the tidal volume, you'll have to go up with the rate, the respiratory rate, because you don't want to risk not having enough for the patient, enough minute volume for the patient. So minute volume is just saying how much did they take in a minute, which is your respiratory rate times your tidal volume. I say normal adult because that it can change so much, because usually it's based on weight, and the weight and the 100 mLs per kilogram a minute is just a generalized, that can change a little bit, but that's what they have as a normal, and that's what we usually use. Respiratory rate is usually determined after you figure out your minute volume and that, and what you would do is you're going to be dividing your VE by your tidal volume to get your respiratory rate. And again, with ARDS and pulmonary edema patients and that, usually the respiratory rate is going to be higher. Another patient dynamics that the respiratory rate would be higher is acidosis from other things like diabetic ketoacidosis. If they started out with a respiratory rate of 32 because they're trying to blow off the acid, you need to match that. Those are times that you have to tweak the respiratory rate. PEEP is an excellent tool to help oxygenate. There's two ways to increase oxygenation on a patient, and that would be increase the FiO2, which we already have it at 100%. And the next way to do that would be increase the PEEP. Normally we have 3 to 5. However, on somebody that is ARDS and pulmonary edema, they may end up in the 10 range. You may be doubling that. It may be higher than that. Always know that when you increase things like the thoracic pressure and increasing the PEEP can also lower the blood pressure a little bit. So watch for that. Any questions on that slide so far?
And Ms. Kathy, I know we're gonna the ventilation thing is a big deal, so we're definitely gonna have another session.
Yeah.
Because that is a very valuable information that they need. We're gonna have another training, and since
Okay,
you're
and the
getting
next
close to the
slide
end,
has more
yes.
too. Okay, great. And then, sorry, this is a very busy slide. I probably should have made it 2 slides, but it is what it is. So obviously you want to monitor the SpO2. Just a reminder, these are super sick patients where they might not have a great hemodynamic status, or there may be other reasons that their fingers, if you will, or their ear, wherever you're putting the SpO2, there's a latency. So when you see somebody that's already hypoxic with the like a monitoring like a finger probe SpO2, they've been hypoxic for a while. So anything that starts into the 80s is trying to turn somebody around like that is very difficult. So that's why I say with certain things, being very, very aggressive to try to oxygenate these patients is utmost important. And so I love the idea that the CPAP was brought on early, BiPAP if you have it, but getting that patient on something that's going to get them oxygenated as quick as possible. Again, acidotic patients need a higher minute volume, also, higher than the normal range. They need the higher respiratory rate and a lower tidal volume. The end tidal CO2 is very important, very, very important. I can't even tell you how much. And the more I learn about it, the more, if I had to choose between having an SpO2 and having an end tidal, I would want an end tidal. And that's for intubation itself, that is the gold standard for confirming, other than if you're the intubator and you saw it go through the cords, obviously that's saying that you're in, if you will, into the trachea. However, it's a gold standard that you get the end tidal connected up right away. If you have a number and you have a waveform, you are in. And when you see changes to that number and changes to that waveform, it gives you a warning that some things might be going on. And I have a graph after this that I'll show you that kind of helps you out with that, and it'll show you how important it is to have. Target the minute volume to achieve pre-intubation end tidal CO2. So it's nice to know. So when you're bagging a patient using a bag valve mask, trying to get end tidal connected to that bag valve mask before you get the patient sedated, paralyzed, and intubated is very good to know. And it's good to know what the pre-intubation end tidal is. And when I talked about ideal body weight, and we base a lot of things on body weight, when you're putting someone on a ventilator, it's very helpful to base that on their ideal body weight, not what their actual weight is, because their lungs are still the same size. So it's based on height. So it's 2.3 times the number of inches over 60 inches. And then you add 50 to that for males and add 45.5 to that for females. I am not a mathematician. When I first saw that, I'm like, oh, that's so confusing. It's actually not very confusing if you just look at the basics. So you're 2.3 times how many inches they are over 60, plus 50 for males or plus 45 for females, and that'll give you an ideal body weight. Minute volume is based on age, and this is just a general. It can be somewhere around 9 for adults, 4 to 5 on pediatric patients, and 1.5 to 3 on infants. High levels of PEEP are likely required on patients with ARDS or pulmonary edema and that type thing. That's a busy slide. Any questions? So the next slide. Oh.
No, I know,
there we go.
Ms. Kathy, yeah, we're already at 8, but we're gonna just add 5 more minutes and then we'll be done. So
okay.
as I say,
And this
presentation is gonna be bigger, yes.
Okay, I'm just basically giving you the graph. Look at the graph and it'll tell you the top left. It shows you what a normal end tidal is with a nice square waveform. When you think about somebody getting bronchospasms or getting a plugged tube or something that's happening, you look for that shark tooth. That's what we call it, like the fin of a shark. That's a little scary thing. Something that if somebody goes into cardiac arrest, you can see in the bottom right. And then when you look for ROSC and you say, oh, I might check for a pulse, because all of a sudden you have a spike in end tidal. That's something to look for. And then just look at all the other things. There's end tidal, and looking at a waveform and looking at the number will tell you a lot. Okay.
Yeah.
Okay, so when we start planning for extubation, so one thing we'll be looking for is on our ventilator settings that our FiO2 is less than or equal to 35. Room air, you want to be closer to like that 20, 28%, but if you can get to 30, 35, that is also good. PEEP, if you had to go to higher PEEP levels, if you were at 8, if you were at 10, depending on how severe the pulmonary edema or the ARDS was, if you can get back to 5, that would be good. And we're weaning sedation, they're able to follow commands, they're calm, they're prepared mentally for extubation. That's always a good sign too, because if you start to extubate before the patient's ready, or if they are still, you're seeing them be too anxious for extubation, then of course they're going to have a higher respiration rate. So they're following commands. And we're doing a breathing trial. So the way we do breathing trials is that we'll set the ventilator to a pressure support CPAP setting. So the patient is initiating their own breaths. That should be about 12 to 30 breaths per minute. And then after they've been on the setting for at least an hour, you're going to do an ABG to see if they're tolerating being able to breathe on their own. And of course, if you change the FiO2 at all, if you change the PEEP, you should repeat your ABG before you extubate to make sure that they're still tolerating and they aren't slipping back into like a respiratory acidosis, or if they're not becoming hypoxic after these changes. If you have x-rays and you're able to trend x-rays, there should be improvement, clear lung spaces, and minimal secretions, because again, if the patient has too many secretions, they're likely not able to clear those secretions by themselves, and they still may need the respiratory support and frequent suctioning. Okay, next. Once you successfully extubate the patient, of course, they're still going to be monitored for labored breathing and dyspnea. They're still going to be on the continuous cardiac monitor and O2 saturation. So if you have a pulse ox monitoring, you can again repeat the ABG after they've been extubated for some time. Make sure that they're not becoming, again, hypoxic, hypercapnic, in respiratory acidosis again. If they're on a nasal cannula or, a Salter, which is the nasal cannula with the humidifier, you're trying to wean that down, hopefully get them back to room air. That might take a couple days. And they're going to need a dysphagia screening before they take any oral medications or food orally. If they're doing well, they're not having any complications, typically we'll try to downgrade care, so they'll move out of the ICU if everything is going great after 12 hours to a day.
Thank you for all the presenters, and we really appreciate. And my apologies for I know Kathy's slides requires a whole class. I mean, having only 2-3 minutes for slides, no, we need the whole class. So when I'm gonna ask you, everybody who attended this meeting, please write in there that, or send us an email, the type of the events you have, the maker, like who design or produce that equipment, so we can get different types. And then the next session is going to be covering just vent, like how you set up the vent, how you go up and down, whatever they were discussing today. We want to be able to go in details, because the vent has to take it by itself. Yeah, right now we just get a test of it, so there's experts here that can share that information. So please send those emails, tell me the type of the vent, send the pictures, so I want to see it. And then so next time when we have our expertise explaining the vents, then they can say this vent setting should be this way. And then in each hospitals, if you can tell me somebody who is good in vents to be able to walk through us how you set it up, that would be great. So then when we're discussing, we have something that is best evidence to try and cover those and explain that part. So I know we ran out of time, but this was a great discussion, and I'm glad people were asking those questions. And so we're gonna send the link after the meeting is over here. We're gonna send the link to the YouTube. Watch that video, send the comments, questions, pictures, and then so the next session we can let you know once we get our expertise, the available date. So probably in a month or so, so to give them time to prepare for the content. So probably it'll be in June to be able to get another date, and then but we need those Vents pictures, so we have an actual picture and the make of those machines. Any final thoughts, say, for the esteemed presenters?
No, I just want to thank them and tell them that they did an excellent job. And Alyssa, I'm proud of you.
Yes, our baby Elisa. Very proud. Thank you, Miss Kathy, Dr. Gwen, as always, Mr. Zachariah. Thank you, Dr. Helen. Wow.
Thank you. Thank you.
Yes.
Oh, Alyssa, hongera sana.
Asante.
Oh, see? Wow. Very good. Very good. I'm impressed. Okay, anything else? Final thoughts, guys. 30 seconds so we can let you guys know.
Nope, thank you so much.
Yes, thank you for being here, Miss Kathy. Yes.
Thank you.
Mr. Ronald is asking. Yes, you get the slide. We send you the slide with the email. Once we get the link of the video, we send the slide with the link. Yes. Anything else? Dr. Gwen, final thoughts?
Great job, everybody.
Yes, Zachariah, final thoughts.
I can congratulate you for a nice discussion. I'm waiting for another on June, so it can be a few words I can say.
Good. Get those event pictures ready, because we want to be able to discuss it with the event, and people have to tell us how you guys do it, and then our experts can walk you guys.
Okay, I will work on.
Yes. Dr. Helen, thank you very much. Yeah, definitely we need your help next time to definitely, from the physician standpoint, how you guys order the order set. If you can, just tell us so what was in there, to see if you have any protocols. I know Dr. Gwen was asking about if the tools you're using. I know Kathy and Elisa spoke about it. So if we have specific care of, like if you follow the guidelines, so we need to be able to share which one works. So if we can get the information early on so people can plan ahead to have something to talk about, that would be great. I think that will help everybody.
Okay, I'll definitely work on it.
Thank
I'll
you.
keep.
Guys, I'm gonna give you back your Thursday, and thank you very much. I appreciate that. It was a great learning opportunities. I learned a few things, at least. Now I can call myself maybe pretend ICU nurse. Bye, guys.
Okay.
Okay, take
Bye.
care.
All right. Thank you,
Bye.
everybody.
Thank you.
Thank you.